clinician's perspective.
Thank you very much. Maybe it would have been better if Jacques was first, but because I will add my own confusion to the other confusion already present when talking about the clinician's perspective. I have no conflict of interest, at least not related to this talk. Just to clarify, it's about demicrocirculation. I don't think there is a demicrocirculation. There are a lot of microcirculations, and they're probably controlled very differently, each of these different microcirculations. There has already been a debate about the question, but I think the question whether the microcirculation under the tongue that we use because it's very accessible, whether that reflects other microcirculations in vital organs, I think it's a wrong question. I fully agree with Sean Inch, because that's what we do with lactate, that's what we do with blood pressure, that's what we do with SeVO2, that's what we do with urine output. All these variables that we use, they are indicators of a problem. And I think the microcirculation under the tongue is no different. In addition to the microcirculation under the tongue, I think a very easily accessible other microcirculation, for instance in the skin, is also a very important indicator of something is wrong. And I think abnormalities in the microcirculation, wherever you measure them, have been shown to be related to morbidity and mortality. Well, if you look at this microcirculation, and that's the beauty of the instruments that you use or that you put under the tongue, if you look at this microcirculation, I think it's a no-brainer that there is something completely wrong here. And this is not artificial, there's no data processing, there is nothing. This is Sakir, a cardiologist, intensivist fellow in Rotterdam, going to a patient to do his regular checkup in the process of his study, puts the microscope, the cytoscan, under the tongue and sees no circulation. The problem is that while he was doing this, the patient was fully awake, talking with him. Well, not at this moment, of course. That's a little bit difficult to talk with that thing in your mouth. Had no complaints, had normal blood pressure and normal vitals, and yet there was no circulation under the tongue, a complete standstill. Well, that's exactly the problem we have been talking about in the previous discussions. What to do when it's abnormal? This is clearly not good. The patient turned out to have a tamponade, or no, pericardial infusion limiting venous return. No clinical tamponade. And the problem really is that the indicators that we have that the microcirculation is indeed grossly abnormal and inadequate, because that's the abnormality is not always a problem. We have patients running around in the hospital waiting heart transplantation, and they walk around with, well, they're not running, absolutely not running. But they're walking around with an index of 1.5. An index of 1.5 hardly ever makes your ICU patient survive. So abnormality is not the key problem. Inadequacy is the key problem. And there we are in a clinical problem because we have so limited parameters of inadequacy. When Max Ariwal did his studies, he introduced a few of these parameters that indicate inadequacy, as we wrote up a year after he died. That's the altermentation, the mottled and clammy skin, the oliguria in some cases, and of course, Max Ariwal's most favorite one, the lactate. And when you draw all of these together, then of course the basis of this problem is the inadequacy of perfusion of the tissue, so the microcirculation. But they don't have to be present, all of them, at the same time. And especially for arterial hypotension, we already know that that's a very bad indicator of inadequacy. Now, the group from France did some very nice studies, not looking at the microcirculation under the tongue, but a very easily accessible microcirculation that Max Ariwal alluded to, and that's the skin. They started off with a mottling score, resulting in an increased risk of dying of 74. So a 74 times more risk of dying when your complete leg, or almost your complete leg, had this discoloration. And they followed up with repetitive studies where they showed that not only the discoloration of the skin was indicative of morbidity and mortality, but also the STO2, the near-infrared of the knee, and also the capillary refill time, a very simple measure, push the skin and look and measure how long it takes for the color to become normal again, or like baseline again. And so all these indicators of skin perfusion were related to mortality in these patients. And so this microcirculation, if abnormal, is also very indicative of something is really wrong. It doesn't tell you what to do. That's the problem. All of these indicators tell you something is wrong. And some doctors don't need any indicator. They walk into the room, they don't look at anything, look at the patient and say, well, this is not good. They don't need blood gases and lactates. And so sometimes it's very obvious, but in general, it's quite difficult. And Daniel de Bakker, in the first study looking at the microcirculation under the tongue, also showed that this microcirculation, when assessed in a one-time measurement, could, let's say, clarify between survivors and non-survivors. The problem with these studies is that if survivors have an abnormal microcirculation, and it's been said before, it doesn't mean that if you correct the microcirculation, they will become a survivor. That's something that Shoemaker tried to introduce many, many years ago. Look at survivors, look at their phenotype in regard to oxygen delivery, oxygen consumption, cardiac index. Then you see a different phenotype in patients that died. Let's fix the phenotype of the dying patient into a surviving patient, and they will do better. Well, we know from the studies from London that that doesn't work. So just changing the phenotype of the patient is not always the answer. And it's not only the one-time measurement that will be indicative, as Yasser already showed, it's also the persistence. And so this graph doesn't tell you that the persistence of the microcirculation causes these patients to die. That's not the observation. The observation is that in patients that die, they have consistently abnormal microcirculation. So the same thing applies, doesn't mean that correcting it will increase survival. Now, are these things difficult to assess? Is there, let's say, a clinical problem in using these parameters? We skipped, for instance, the capillary refill time many years ago from the emergency protocol in the ambulance service in the Netherlands because they said there was too much inter-rater variability in using capillary refill time. Michel van Genderen did a very simple study. He asked nurses and intensivists to measure capillary refill time, and then the research fellow, as the gold standard, measured the refill time. And as you can see, there was a very good kappa. So if you use, in this case, we use 5 seconds, so not 4.5 seconds, that's the average in studies, but a very simple to get 5-second period. We have in the rooms all these clocks with very easily accessible seconds, and so it's very easy to see 5 seconds. 4.5 is, of course, ridiculous. So by using this 5 seconds, you get a very good inter-observer variability. And Alex Lima from our department, research fellow who is postdoc now, also used the microcirculation because you have the same problem. Can you use the microcirculation under the tongue, and will two people have the same evaluation of this microcirculation? When he used, let's say, normal, abnormal, you had a very good kappa. If you made it too much discriminative, it was somewhat more complicated, but with normal, abnormal, he found a very good relationship between people, nurses in the Netherlands, in Uruguay, Japan, using pig data. This is not patients, but this is movies from pig. And so, yes, these methods are indeed easy to use, accessible, and reliable. And in clinical problems, like in hypovolemia, these parameters follow the physiology that's going on in your patients. Something that Sebastian Bartels, PhD student from our department, showed when we did a simulation of hypovolemia, put a patient or put a volunteer in a lower body negative pressure chamber thereby limiting venous return and so decreasing stroke volume. What he found is if you decrease stroke volume by increasing the negative pressure in the chamber, that you will have a decrease in your microcirculation. So this is at 0, and this is at maximum minus 60 millimeters of mercury, and you will see a decrease in microvascular flow. You will see a decrease in perfused vessels. So indeed, this parameter under the tongue follows physiology in these controlled experiments. And correction of a problem, and there are many methods already published that will correct an abnormal microcirculation. For instance, this one, I just took one because I don't have the time to go into all of them. If you have an abnormal microcirculation and you have low blood pressure, it makes sense to see whether an increase in blood pressure might correct your microcirculation. And in the study from Arnaldo, it was clear that in patients with abnormal microcirculation and abnormal blood pressure, it made sense. If your microcirculation is normal and you collect a low blood pressure, that's not good. It will decrease your microcirculation. And so if the end of where you want to be, normal microcirculation, is already there, then don't start to correct macro hemodynamics. And especially don't increase your central venous pressure. As I talked about in the talk on mean systemic filling pressures earlier on, the mean systemic filling pressure and the central venous pressure are, let's say, the back pressure of your microcirculation. And it's, in order to decrease the microcirculation, you only need very small increases in central venous pressure or post-capillary pressure to limit perfusion. And that's why Mathieu Legrand found this a relationship between increasing central venous pressures in septic shock and the occurrence of new kidney injury. And the basis is probably the increased post-capillary pressure, as Namke Vellinga from Leeuwarden showed, that if you look at patients with low central venous pressure and higher central venous pressure, there is a significant difference in the microvascular flow index. So that could indeed contribute to the observation of Mathieu of new increased kidney failure. And if you have this problem, if you have abnormality, next to blood pressure increases, you could also use a vasodilator like Alex Lima showed in a recent publication in Critical Care, where he showed that if you give nitroglycerin as a way to decrease venous pressure and to open up the microcirculation, when your microcirculation is abnormal, that was the inclusion criteria for the study, by whatever means you assess this abnormality, either capillary refill time, perfusion index, STO2, doesn't make any difference. If you titrate nitroglycerin, you completely normalize everything. When you turn off the nitroglycerin, everything becomes abnormal again. So it's accessible and it's treatable. And how to use it in clinical practice? Well, like I said, if your microcirculation is normal, don't start to correct abnormal macrocirculations. Just like fluid unresponsiveness, I think there's a complete misconcept of fluid unresponsiveness. If you have a normal microcirculation, like in this study from Eva Klein, who will do her PhD thesis on Friday, if you have a normal microcirculation, MFI, MFI of 3.3, so that's a completely normal micro perfusion index. If that is normal, then correcting the fluid responsiveness doesn't make any sense. It won't correct anything. So these were patients with a clinical problem, low blood pressure or whatever, and she looked at fluid responsiveness. And whether you were a responder or a non-responder, the microcirculation didn't benefit from this. So resolving fluid responsiveness with a normal microcirculation doesn't help. So the assessment of the microcirculation could help. And Michel van Genderen already showed that if your periphery is normal, you can grossly limit the amount of fluid you give to resuscitate these patients. This paper came out in the Blue Journal early this year, where he basically said if your microcirculation in the skin is normal, you're not allowed to give fluids to correct for a clinical problem. It's an update on this one. And is there any relationship with something vital? Because this question keeps on coming up. Is there a relationship to vital organs? Well, Andreas Brunauer, the group from Martin Dunzer, looked at this, and they looked at the relationship between capillary refill time, so this indicator of something wrong in a microcirculation, to the vital organs. And they did it with the Doppler measure of vascular resistance index, a little bit complicated as a true measure of organ perfusion, but I mean, to assess these organs in an attack patient, it's the only one we have at the moment. They looked at the kidney, the liver, the spleen, and the intestine. And what you can see here is on the x-axis is the real time of capillary refill time in seconds. And remember, 5 seconds we used to assess normality and abnormality. And here is the resistance index on the y-axis, and you have to read it like the higher the resistance index, the lower the flow. And so what they found in liver, spleen, intestine, and kidneys, the longer your capillary refill time, the worse your vital organ blood flow in the liver, the kidneys, spleen, and intestine. So there is a link between this indicator of abnormality in a microcirculation and your vital organs, if you're interested in that. So just to clarify and to repeat, I already said this, but I think that at the end, the abnormalities in the microcirculation are indeed related to morbidity and mortality. The question is, does the patient benefit from correcting it? We have to do studies for that. Our point when we wrote this editorial or this viewpoint, Martin Dunzer, Jukka Takala, Andreas, and me, we said, well, if your microcirculation is normal, and that should be the end point of your resuscitation, if you reach that end point, then don't worry too much about the macrohemodynamics. Don't worry about the cardiac output of 2 liters index if your microcirculation is completely normal, because people walk around with 2 liters indexed cardiac output. So that could be adequate. The key point in clinical practice is indicators of inadequacy, and I think that's where we should focus on in the next years. Thank you very much.